Good morning, everyone, and welcome to today's PQA Quality Essentials Webinar. My name is Amanda Ryan, and I am the Director of Education here at PQA. Today, we're going to be talking about the implementation of PQA measures and also explore their use in CMS programs and beyond. But before we get started, I would like to call your attention to 3 housekeeping items. First, please submit your questions during the presentation. You can use the Q&A feature that's at the bottom of your screen within Zoom webinar, and we will have a question and answer session in the latter part of the session today. Second, the webinar recording and the slide deck will be made available to PQA members within a week following the presentation, and that will be on the member resources section of the PQA website. And then lastly, I would like to encourage everyone to please take the 1-minute survey that will launch at the end of the webinar. We always do appreciate your feedback. And then for our session today, we do have a 4-part agenda. First, we are going to be sharing a high-level overview of PQA's measures. Next, we will discuss how PQA measures are used within CMS programs. And then we will share a brief summary of how PQA's measures are used in other programs. And then we're going to wrap up with some information on PQA's measure licensing process, and then also how you can request technical assistance if you would like that on PQA's measures. It's now my pleasure to introduce the staff from PQA's performance measurement team that will be presenting with us today. First, we have Ben Shirley. He is the Director of Performance Measurement here at PQA, where he provides expertise in several phases of the measure development process, and that includes specification, analysis, and consensus-based endorsement. Next, we have Lisa Hines, who is PQA's Chief Quality and Innovation Officer. As a member of the senior leadership team, she develops, establishes, and implements the strategic direction of PQA's performance measurement and research initiatives. And also with us today, we have Rachel Digmann. Rachel is the Senior Director of Measure Operations and Analytics here at PQA. She is responsible for measure testing and maintenance of the PQA measure technical specifications and also contributes to the development and endorsement of PQA's measures. And with that, I will turn the floor over to Ben.
All right, thanks very much, Amanda. Can you hear me all right?
Yes, sir. You sound good.
All right, great. Well, thanks everyone for joining this morning. We are really excited to hold this webinar with you all, talk a little bit about PQA, about implementation. Before we do dive into sort of the meat of the presentation, I think we do want to just take a few minutes here to give an overview for those who aren't as familiar, or for those who could use a refresher, of PQA's development and stewardship process here on the next slide, just to give everyone a little bit more context as we think together about the implementation of PQA's measures. So on the next slide, you can see we have a clearly defined, transparent, and consensus-based process that we do use to develop PQA's measures throughout the life cycle. You can see that laid out step by step on the slide here. The first stage is going to be conceptualization. So that's where we identify and prioritize concepts to be developed. This process can include things like environmental scanning, convening of panels, public comment from PQA's members and others. And really the goal of that is to identify priorities and direct PQA's resources towards those measures that have the most potential to have an impact. The second stage is specification. So really what we're doing here is translating the idea into the language of measurement. So that's creating a numerator, a denominator, measure logic, value sets, the associated codes, really everything that you need to actually calculate a quality measure. We do also do a little bit of initial feasibility testing here to make sure we can actually calculate the measure and that the idea is feasible. And we do collaborate with a technical expert panel made up of highly experienced and clinically experienced members of PQA's membership here as well. So that is a partnership between PQA staff and those technical expert panels. Once we have a firm specification, we do move into the measure testing phase, and that's going to involve both PQA's internal data assets as well as partners with external organizations and the data assets they hold. And some of the answers that we might look to answer during testing are things like, how many people does this measure affect? What does the performance look like and how is it distributed across entities? Is it statistically reliable? Are there disparities? Things like this really help us understand how a measure is going to function in the real world. Once the measure is tested and approved by both PQA staff as well as our quality metrics expert panel, it does go to PQA's membership for an endorsement. That's the measure endorsement stage of the measurement lifecycle. All of our members, PQA members, can cast a vote as to the appropriateness of the measure for PQA endorsement, with endorsement really signaling that this measure is ready for use out in the world in quality programs. And then finally, the road does not end with endorsement. We like to say there's no such thing as a final measure because evidence changes and we learn from measures that are in use. So we do dedicate a lot of resources to stewarding our measures over time towards measure maintenance, making sure they reflect the most recent evidence, the most recent indications for drugs, and all of this. And also in that bucket, we put implementation, which we're going to talk a lot about today. So once our measures are developed, we start thinking about where they can best fit into quality programs to make an impact in the healthcare system. So PQA does steward and develop measures across several different domains. This is just a helpful way of thinking of the measures that PQA stewards. So we have adherence at the top there, including the PDC measures that many folks are very familiar with. It's going to be diabetes, ROSs and statins, the Medicare big three, but also a number of other diseases and medication classes, from beta blockers to antiretrovirals, some specialty conditions like MS, hepatitis C. So a pretty broad portfolio of adherence measures. We have appropriate use measures, which is going to include things like statin use for persons in diabetes or SUPD, measures like INR monitoring for individuals on warfarin, et cetera. We have sort of a broad range of measures under the umbrella of safety. That's going to include the polypharmacy in older adults measures, as well as the opioid core measure set. And then finally, the medication management services is the final domain. So that is going to include the CMR completion rate, the medication therapy problem resolution, and many other measures. Each of these domains have many more measures than those listed here. These are just to provide some helpful examples. So one thing that we also like to point out is that PQA develops and stewards measures at multiple levels of analysis. And some of you may have heard this levels of analysis term referred to maybe as different levels of attribution as well. Those are synonymous. But essentially, the idea is that measures can be specified for use at different types of healthcare entities. So most of PQA's current measure portfolio is measure specified for health plans. That means that the measure was designed and tested and endorsed for use in health plans at the health plan level of analysis. So an example of a health plan measure, right, would be that statin use in persons with diabetes measure that's in the Part D star ratings, which is a health plan quality program. However, as many of you may also know, PQA is developing quality measures at the pharmacy level of analysis. And this means that these measures are designed and tested and eventually endorsed for use at the pharmacy level of analysis. Pharmacies differ from health plans as a measured entity in a lot of, I think, both obvious and subtle ways. Certainly they contribute to patient care differently. They have different interventions available to them. They have distinctions in technical aspects like denominator sizes. If you think of the number of patients that a pharmacy has versus an entire health plan, obviously there's quite a discrepancy there. So really an example of a pharmacy performance measure that PQA is currently developing would be the specialty turnaround time measure. That's something that we're currently developing and hopefully we'll be on track for a membership endorsement consideration this fall. But really we call this out to note that measures should only be used at the level of analysis for which they are specified and tested. Because if they're used at other levels of specification, they might not be reliable, they might not be valid, they might not be something that that entity can actually meaningfully influence. And we just really don't know that it's going to be appropriate for that use. So as a consensus-based organization, PQA members do vote to endorse quality measures that we develop and steward, which signals that those measures, again, are ready for use out in the world. But in some cases, PQA may also choose to pursue National Quality Forum, or NQF, endorsement. NQF is another consensus-based organization whose endorsement signals best-in-class designation for quality measures. It's important to understand that NQF endorsement, right, is a high bar to cross. It requires a substantial amount of resources from PQA to navigate the process, to develop the submission documents, etc. The submissions also have to be resubmitted each 3 years for maintenance, which means it's not just a substantial investment, but an ongoing one. And since it is such a lift, we really try to be strategic, and we really only submit measures where we believe NQF endorsement is going to confer a meaningful advantage in terms of potential adoption or implementation. And you actually might hear about some of those instances later on when we're talking about specific programs. But with that sort of background, PQA does maintain a significant portfolio of NQF endorsed measures listed here on the slide. So that's going to include PDC, statin, RASA, and diabetes, INR monitoring for individuals on warfarin, use of opioids at high dosage in persons without cancer from multiple providers and persons without cancer, and from multiple providers at high dosage in persons without cancer. Also, we have the concurrent use of opioids and benzodiazepines measure, annual monitoring for persons on long-term opioid therapy, and initial opioid prescribing for long duration, which is the most recently endorsed NQF measure. So with that as background, it's really time now to move into the main portion of this webinar, which is going to focus primarily on implementation of measures. And just to make sure that we're all sort of working from a common lexicon, right, a common understanding, when we talk about implementation, what we mean is the use of PQA measures in quality programs. There are a lot of different kinds of quality programs. There are accountability programs, meaning they typically have some sort of monetary or other incentive attached. There are quality improvement or public reporting programs. There are national versus state versus local, public versus private, etc. But ultimately, at the end of the day, programs in large part are what make measures meaningful. It's how measures have an impact. And to start out with, since this is sort of the primary concern for at least some of those on the line, we're going to start out with CMS and provide a little overview here. And what we think is important to understand sort of to start out is that CMS has a pretty wide-reaching quality strategy that they execute through a lot of different programs aimed at a lot of different goals through a lot of different types of providers. So this list that's here on the slide is sort of intentionally daunting for that purpose, to sort of show you how many different programs CMS has going on from a quality perspective. You can see here there's everything from inpatient rehab, there are several hospital programs, there are ASC programs, psychiatric facilities, SNF measures, the quality payment program, which is the umbrella over both MIPS, the physician side measures, as well as a lot of alternative payment models, and a large jumble of other things. And the takeaway here is that for PQA, for health plan and pharmacy, medication use related measures, we actually cut out a pretty small corner of this map, as you'll see on the next slide. And so this really is the corner. Oh, sorry, Amanda. Next slide. I just meant the progression there. Thank you. And essentially, this is the corner, right, where our measures are primarily implemented. We have there the Medicare Part C and D star ratings, which is an accountability program within Medicare. There's a health insurance exchange quality rating system, often abbreviated just to quality rating system or simply QRS. And that's going to be public reporting for plans on the individual market, so through healthcare.gov or state-based exchanges. And finally, we have the Medicaid Adult Core Set, which, as you might guess from the name, is a public reporting program for state Medicaid programs, although the program itself is run nationally. So now I think we can dive a little bit deeper into each of these program by program. So to start out with here, let's talk a little bit about the Medicare Part D star ratings. So the goal of the star ratings program is to provide quality and performance information to Medicare beneficiaries to assist them in choosing health and drug services. The program does produce a rating, a star rating out of 5 stars that displays to consumers on Plan Finder. Ideally, the goal is that this helps people looking at different plans differentiate between the quality of them, and in some cases opt for plans with higher star ratings versus lower star ratings. It's worth noting that Part D measures do apply both to Part D prescription drug plans, which are frequently going to be referred to as PDPs, as well as Medicare Advantage prescription drug plans, often abbreviated to MAPD. So although the stars do display for both of these plans, there are different underlying incentives that are important to understand, the most impactful of which is probably the quality bonus payments on the MAPD side. We would probably actually need a whole nother webinar to clearly lay out exactly how MAPDs are reimbursed and exactly how quality bonus payments fit in and are calculated. But suffice to say, there are substantial incentives related to the quality bonus on that side that are important to understand beyond just the public reporting of stars to consumers and the other aspects of the program. So from a nuts and bolts perspective here, the construction of the, go back one. From a nuts and bolts, just looking at the perspective here of the construction. So the Part D stars are composed of 14 measures across 4 domains. Those domains are going to be drug plan customer service, member complaints and improvements, member experience, and drug safety and accuracy. And that last one is where most of the PQA measures will be focused, since that's sort of the clinical domain. Each measure contributes to a rating at the domain level, then gets aggregated up to the summary and overall star ratings. And for those curious about public reporting of these measures beyond what's on Plan Finder, CMS does release this data in an easy to use Excel format on a regular basis. I do realize that you can't click the link through this Zoom, but I think if you just Google Part D performance data, the first result that'll come up should be the CMS webpage where you can download that. It's valuable to be able to track, measure rates over time within plans, across plans, et cetera. So now in the next slide, let's think a little bit about how a measure gets implemented into Part D and how long that takes. As someone who does new PQA member orientation, right, and I also answer some technical assistance questions, I can definitely attest that the question of how long until something becomes a star measure is going to be on the Mount Rushmore of questions asked to PQA consistently. And the answer, in short, is that it takes a long time. It's a long progression. Looking at the slide here, the first step in this process is addition to the patient safety reports. So for measures selected by CMS, which will typically be announced in either a call letter or some other official CMS communication, the patient safety reports are going to provide contract level numerators and denominators directly to plans. So this is not publicly reported. It's intended for internal quality improvement to show where a given plan is in comparison to a benchmark based on peer performance, and really just to help them have the tools to improve on some key clinical quality measures. Some measures, right, are only ever going to be patient safety reports, and that's fine. Those measures can still be very impactful. But for measures that are moving sort of from patient safety reports through the process to a star measure for the purposes of this example, you can expect it to spend at least 1 to 2 years in the patient safety reports before making the next step. And the next step there is going to be the step up to the Part D display page. You can see here on the slide, we note that this is public reporting light. I think that this is because despite the name, display measures actually are not, displayed publicly on Plan Finder like you might anticipate. They're not necessarily shouted from the rooftops by CMS. But the key thing here is that they are publicly available. And that's a key distinction versus the internal only patient safety reports. So the displays are available for download from CMS in those same tidy Excel files you can get star ratings year over year from. And from a timing perspective, there are typically going to be at least 2 years spent in the displays before making the next step. And after those 2 years are up, measures can start the process of going into the STARS program. But in order to make that jump, measures actually have to go through what's called both the pre-rulemaking process and the rulemaking process. And we're going to dive a little bit into what that means on the next slide here. So what do these words mean, pre-rulemaking and rulemaking? Well, essentially, the 3 colored slides, or rather 3 colored arrows at the top of the slide here, those are reflective of what is called the pre-rulemaking process, which is essentially a system or a process through which CMS is gathering input on potential measures for addition before officially codifying them through federal rules. So this is going to start with the submission of measures to the CMS Measures Under Consideration, MUC. You'll frequently hear it called the MUC list. And that's going to be open for submission from developers. CMS may submit measures on its own. And that typically is going to be open on an annual basis until around May. So that'll be open for a few months for submission. That then produces a list, the MUC list of measures that are going to be evaluated by an important group called the Measures Application Partnership, or the MAP, the MAP. So that's going to be the middle arrow there. And what the MAP is a multi-stakeholder group, actually a series of groups, that meet for the express purpose of recommending measures to CMS for implementation in their programs. So that group typically meets in the late fall, early winter, maybe in November or December. They have a series of work group meetings where they're considering all of the measures on the MUC list against a series of standard measurement criteria, many of which are going to look familiar to you all, things like importance, scientific acceptability, feasibility, fit with the strategic priorities of CMS, et cetera. And what they do is on a measure by measure basis, they make recommendations to CMS, typically in 3 categories. They're going to say, we recommend this measure to move forward to rulemaking, meaning they're giving it the green light. They are going to say, we do not recommend this measure to move forward for rulemaking. That's going to be the red light. And they recommend that this measure move forward for rulemaking contingent on either some adjustment to an issue that the MAP had with the measure identified during those meetings, or most frequently, they will say our recommendation is contingent on NQF endorsement. So you might recall that we said that we pursue NQF endorsement when it's a strategic priority for implementation. Well, here's exactly where that might actually play out in practice in the pre-rulemaking process. So from start to finish, MUC list all the way through MAP input, that's typically going to be about a year. So you can add that to your running tally of years between a patient first entering CMS and going to a STAR measure. So the MAP produces those recommendations in a final report. Then it basically takes that report, it thinks it over, it considers that input, and evaluates which measures it's going to put forth in the proposed rule. So the proposed rule being a federal document, it has to go through a formal process involving public comments, involving publishing in the Federal Register, subject to PRA requirements and sort of the other onerous pieces that tend to go along with federal rulemaking. So this is also going to be a little bit of a relatively slower process. Following the proposed rule, CMS is going to look at the public comments that came in through the Federal Register. Typically, the changes it makes in response to those comments are going to be fairly small, although it's not completely unheard of for substantial changes to be made if commenters have a very strong reaction or identify some major flaw in the proposed rule. But after that, the final rule is published or deployed, to use CMS's lexicon. That officially codifies the addition of a measure, typically in the following year. And that really is sort of the finalization of the measure as a STAR measure. Typically, they will then start gathering data on the measure in the next year. There's a 2-year data lag in the STARs. So the final rule for 2020 would mean that data collection is starting in 2021 for STARs year 2023, although that may vary from year to year and rule to rule. So that is a lot of information. It goes to show that the life cycle of a Part D measure and the way to get to the STARs, the pathway is pretty long. But STAR measures are very impactful, as we all know, and it's good that this process is slow, deliberate, careful, and that we take the care to get things right. So on the next slide, another question that we frequently receive is, how do you know that PQA measures or any measures in Part D are actually making a difference for patients? Well, that's actually a question that CMS dedicates fairly substantial resources to answering. As you might imagine, it's definitely in their best interest to understand if this whole quality strategy, this whole initiative that we've invested so much in over the last decade or two is actually affecting patients. And to that point, they do conduct what's called the National Impact Assessment Reports. Those are published on a regular basis, I believe usually every 3 years. And that's going to examine the effects of quality measures in CMS programs, including Part D. And what we can see from that report is that actually the effects are pretty substantial. So you can see here on the slides, this is just looking at a subset of measures, the 3 adherence measures, but we can see from a cost saving perspective, from diabetes, a ceiling of maybe close to 4 billion in savings, close to 20 billion for RASA, 3 billion for statin, and we can look at the beneficiaries that are additionally adherent over baseline. That's 500,000 for diabetes, 2.5 million for RASA, nearly 3 million for statin. For those who are curious, also baseline is calculated by taking the growth rate before the measures were implemented in terms of adherence and then extrapolating that out versus how it actually happened with the adherence. So that's just a little insight to the calculation there. Also, although performance on adherence measures is continuing to improve, which is great, we're always happy to see that. That means good things for patients. The rates have remained below the CMS prescribed top out criterion of 95%. Furthermore, we know that by stratifying these measures by key socioeconomic and other variables, we see a lot of room for improvement. And even when rates are high, they don't necessarily look the same for everyone. They don't look the same for all subpopulations, which means there is room for improvement and there's still work to be done. And PQA is working closely with some other key players in the quality space as we evaluate how best to move forward with things like measure stratification. This is a big priority for everyone, us included, and we look forward to that strategy as it evolves in the years to come. So with that, we can pivot a little bit. That was a lot about Part D. I think a lot of you are familiar with that. Maybe less of you are familiar with the quality rating system, which I'm going to be referring to as the QRS. So the goal of the QRS is to provide quality and performance information to individual market beneficiaries to assist them in choosing qualified health plans, or QHPs. QHPs, for those who aren't in the know of the individual market lingo, those are plans that meet the requirements to be sold on the exchanges. So those plans are going to have to meet specific requirements around things like network adequacy, formulary construction, cost sharing, service area, et cetera, et cetera. They have specific reviews that they need to pass to then be certified as QHPs and sold on the marketplaces. The construction of this program is 27 clinical measures, 10 survey-based measures. Annual ratings are released on the exchanges to consumers with performance data, again, released by CMS for public use. You can get that by Googling QRS data, or perhaps CMS QRS public use files is actually the term that CMS uses for those data sets they release. So QRS is a public reporting program designed to help consumers choose high quality plans. It is not an accountability problem with incentives the way that Part D is. So that's an important distinction to understand. There are not dollars and bonus payments on the line in the QRS side of things. And go to the next slide. As far as implementation, you can see this is definitely a bit less information to absorb than the Part D program. I guess a light history lesson, initially when measures were being considered by the QRS. It's a much newer program essentially than Part D, since exchanges were established, under the ACA. Once the ACA was passed, it took a little bit of time to get the program up and running. And the original QRS measures really were heavily sort of developed and sourced from independent groups under contract, meaning that from the start, there was less of a need for this sort of holistic consensus-based adding process, since there were these purpose-built measures being developed under contract, and there was sort of this pipeline of measures ready to go into the QRS. So that's just a little bit of historical context for you all. But as you can see here on the slide, step one, initially measures are sort of selected and considered by CMS for potential addition. Those potential additions are released via the draft call letter for public comment. They can get some feedback from the measurement community, from the measured entities. And then pending any revisions based off of those comments that they do receive, those are going to be finalized in the final QHP call letter. It's also common for new measures to undergo, I actually don't know the technical term for it, but you can think of it as a trial year. So it's frequent that data will be collected and reported internally for a year as sort of a pilot year before being publicly reported. It's often a good idea to get out ahead of any data hiccups. And so the final program we're going to touch on here is the Medicaid Adult Core Set. And the goal of the core set is to publish and track state-level quality measures for adult beneficiaries and to estimate the national quality of care for Medicaid beneficiaries. And it's worth noting, just for everyone's awareness, there is also a related measure set that's going to be the Child Core Set, which follows the same process, has the same goal and mission as the Adult Core Set, but as you might imagine, it is aimed at children as opposed to adults. So from a construction perspective, the Adult Core Set does include 32 measures across 6 domains. Those domains are going to be primary care access and preventive care, maternal and perinatal health, care of acute and chronic conditions, behavioral health care, which is where PQA's measures are implemented, experience of care, and long-term care. For this program as well, we're going to see annual ratings released on Medicaid.gov. And really the goal is to have as many states reporting on measures in the core set as possible. It's important to understand that so far the core set has primarily been a process of report as you're ready, report as you can, as you're able. And CMS has only publicly reported measures that at least 25 states have reported. So if reporting is not fully mandatory for states and you want more states to be reporting, you might imagine that they actually put a very high weight on things like ease of calculation, burden, and feasibility in sort of the charter of the Medicaid core set. They really want these measures to have minimal burden, so as many states can be reporting them as possible, and we can get a good snapshot of sort of state by state and national Medicaid quality. But it is worth noting that that is going to start to change, that optional nature, at least for the behavioral health domain. All of those measures will be required reporting by 2024. That is actually statutory, that's in the law, that cannot be changed easily at all. So definitely a big priority of the core set folks and the core set team right now is getting all the states to a place where they are able to report all of those measures. Since I think that the idea behind the statutory requirement is just that by 2024, the program should be sufficiently mature that we can start to require all states to report, and we can start to, again, get a good picture of national health, starting with behavioral health, which we all know is a really important domain, especially in the Medicaid line of business. From an implementation side here, there is a well-defined process for adding measures. Again, with the core set, we're sort of in the land of statutory requirements. HHS requires by statute annual review of these core sets. That's going to be addition and subtraction potentially. And to accomplish that, what CMS does is they convene a multi-stakeholder work group that reviews these measure sets in each of the domains and considers them against the criteria to see if there are measures that are potential candidates for addition, measures that fill gaps. And frequently they'll also consider whether measures are topped out or can be removed because, for example, as I said, feasibility is a big issue. If we're some number of years into the program and it's a great measure, but only 2 or 3 states have ever been able to calculate it, I think that the core set just sort of has to accept that this measure is not going to be a good fit for the program, even though it might be a good fit for other programs. So those are the sort of decisions that the work group is going to be making on an annual basis. Compared to Part D, for example, this is a pretty streamlined process, at least to be added to the core set. There's not this long on-ramp, right, of patient safety to displays, rulemaking, pre-rulemaking that we discussed for Part D. Although it does help frequently for candidate measures for the core set if a couple of state-level Medicaid programs have been using the measure previously. That helps during the work group meetings for those states that are already using the measure to say, hey, we've been using this, it's meaningful, it gives us good information, and we can calculate it pretty easily. The other states, the other members of the work group tend to attach a lot of weight to that since it's real world experience. And the key, as I mentioned before, this program has been report as you're ready. So being implemented is not a guarantee that everyone is reporting on core set measures, although that will change moving forward, as I mentioned, starting with the behavioral health and then eventually extending to other domains. You can see on the table on the right of the slide here, actually, they report sort of the layout of the measure counts, who's reporting what. You can see that 46 states are reporting at least one measure, but the average state is reporting about 22.5 out of 33 measures. That's about 2/3. It could be worse, but not reporting 1/3 of the measures in a core set is obviously not optimal. So there is a ways to go here, with only 25 of those 33 measures being reported publicly, meaning only 25 of those measures have enough states reporting to be publicly reported. So that is sort of a high level or maybe a medium level overview of sort of the 3 key CMS programs, although there are others that PQA measures are in, the Part D stars, the Medicaid adult core set, and the quality rating system. So now I'm going to pass it to Lisa to talk a little bit more about how PQA measures specifically fit in.
Thanks so much, Ben. So Ben provided a fantastic overview of how many of PQA's health plan measures get implemented into CMS quality programs. I'm going to talk about where our measures are implemented in CMS programs, as well as some other uses of PQA measures. So we have approximately 41 measures and quality improvement indicators. 13 of the health plan measures are implemented in Part D. All of the measures on this slide are reported in the patient safety reports. 5 measures have reached the star rating status. And these measures do compose a large proportion of the Part D summary score rating, in part because 4 of the measures are triple weighted currently. The 3 adherence measures and the statin use in persons with diabetes measure is currently triple weighted. We also have several measures on the display page, and all of these measures are cross-cutting across our 4 domains that Ben mentioned: adherence, appropriate medication use, safety, and medication management services. So the display page measures can sometimes stay there forever and or for a long time and not progress to star ratings measures, but it is an interim step to become a star measure, pending pre-rulemaking and rulemaking decisions. We do have several measures that could be potential star measures in the future, again, through the pre-rulemaking and rulemaking process. So there is a time lag. And those include the opioid measures and the polypharmacy measures, the concurrent use of opioids and benzodiazepines, and the use of opioids at high dosage in persons without cancer, and use of opioids from multiple providers in persons without cancer. And then the 2 newer polypharmacy measures, use of multiple anticholinergic medications in older adults, and one associated with multiple CNS active medications. 2 of the measures have already gone through the pre-rulemaking process. That was the OHD and OMP measures, and they were recommended as suitable for addition to the star ratings pending rulemaking. And we anticipate 3 additional measures up for review: the concurrent opioid and benzos measure and the 2 polypharmacy measures, to go through that vetting process. And then there's 2 measures that are only reported on the patient safety report, so these are not publicly available, and but plans do receive reports on their performance. The proportion of days covered antiretrovirals has been patient safety reports for a long time. The initial opioid prescribing for long duration the plan is that it will likely become a display measure in the coming years. So that will be an important measure to watch, in addition to the measures that could be potential star measures in the future. And we do have a description of PQA measures in the Medicare Part D program. It's one of our most hit websites or subpages, and it provides great information. We update it as we can based on publicly available information. And so encourage you to visit the PQA website delineating Medicare Part D use. On the next slide, we have 5 measures that are used in the quality rating system. And what we like to see is alignment of our measures across programs. So the 3 adherence measures or PDC measures that are used in Medicare Part D stars are also in the QRS and have been for many years. 2 newer measures, which focus on medication therapy and would be appropriate for implementation in other programs, are annual monitoring for persons on long-term opioid therapy and INR monitoring for persons on warfarin. So both of those are also endorsed by the National Quality Forum, and they could be appropriate for use in other programs, including Medicaid. And we do have a information page where qualified health plans can access the value sets for use in this program associated with these measures, and the specifications are available on the QRS website. And thank you. And then we have 2 measures. So these measures are, again, also used in the Medicare Part D star, or their display measures could be stars in the future. Use of opioids at high dosage and the concurrent use of opioids and benzodiazepines. So we anticipate that these 2 measures will be reported across all 50 states by 2024 because they're included in the behavioral measure set. And we are seeing a lot of use of these measures as core opioid prescribing measures to evaluate patient safety. On the next slide, we wanted to highlight where the measures are used across CMS programs. There is really good alignment, opportunity for a little bit more. The 3 adherence measures, the opioid measures, and then we have the 2 newer measures, the INR and AMO measures that are used in the quality rating system. There's also measures, PQA measures that are used for monitoring purposes only. The opioid measures are used in the Medicare Shared Savings Program, but that's not publicly reported. And those measures were specifically tested and evaluated for use at that level of attribution. On the next slide, I wanted to highlight broader use of PQA measures. So obviously CMS implementation is an important use and a driver of other use of PQA measures. All over the place, use can be public reporting, it could be pay for performance programs, it could be Medicaid waiver programs, grants, research, or quality improvement programs. So there's a variety of types of use, and it can be national, state, regional, and even smaller levels of evaluation. So there are 30 states that are either have or have pending 1115 substance use waiver programs, and this allows them some flexibilities for managing patients with substance use disorder. PQA opioid measures are a part of the required reporting for that program, and so this is a driver for use. Since states are already using it for the waiver program, they'll often report them also on the Medicaid adult core set. On the next slide, I just wanted to highlight some more cross-cutting uses of PQA measures. Early on, Washington State Healthcare Authority developed or established a common measure set and added in the 3 adherence measures that are in the Medicare Part D Star Ratings program. So those measures have been there for a long time and are across lines of business, and they're all payer claims-based data set. And then PQA's opioid measures have also been reported on dashboards in Washington State. So some use in Washington State to highlight. Also, New Hampshire Medicaid requires reporting of 9 PQA adherence measures, and as well as the opioid measures that are in the Medicaid adult core set. So I included links to these sites. We like the New Hampshire site because it's easy to navigate, and you can see data displays of performance, and it's alphabetical by measures. They require a lot of measures. And then there is a research collaborative, the Academy Health Opioid Use Disorder Research Collaborative, that involves 9 states that were hard hit by the opioid epidemic. And this is in yellow on the slide. This is based at the University of Pittsburgh, and they collaborate to calculate on PQA opioid measures for research to inform substance use disorder policy. So they've been a strong user of PQA opioid measures over time and provide some really great feedback. So it's kind of a hybrid of research and policy, and many of these states also report in the adult core set on the opioid measures. And then going to California, sorry, back to the map. I'm going to cover all the colors. So I went blue, green, yellow. Dark green is California. California has some innovative value-based programs. One of them is Integrated Healthcare Association's Align, Measure, and Perform program. And they, this is across several lines of business, and it includes PQA's 3 adherence measures, the statin use in persons with diabetes, and the concurrent use of opioids and benzodiazepines measure. And that program's been in place for several years and is an example of a kind of innovative value-based program. And then there's some more programs popping up in California, including there's a California Quality Incentive Program that applies to the public health systems. They use the 2 opioid measures in the Medicaid adult core set. So you can see states aiming to align with federal programs. And that reduces burden on the measure users. And then also the CDC has had long-term grants to support now in all 50 states and Washington, DC, programs to address diabetes, heart disease, and stroke risk. And in these programs, they use many of PQA's adherence measures that focus on cardiovascular medications and diabetes medications. So that's across all 50 states. And they use those for evaluation over time. So this is an example of different types of use, including state-based, regional, grant-based research, and then there's one-off states that license many of our measures as well for internal reporting purposes and hopefully publicly. Okay, so and then moving on, I will hand it over to Rachel to talk about our measure manual, our licensing, and how to get technical assistance.
Thanks, Lisa. Next slide, please. Thank you. So I know we have a lot of questions to get to, so I'm going to touch on this a little quickly. So as Ben mentioned at the top of the presentation, PQA currently stewards numerous quality measures related to medication use. And the measure manual provides the guidelines and detailed specifications for implementation of our measures. So on this slide, you can see this is sort of an excerpt or a snippet of what the measure manual actually looks like. And the measure manual is typically updated and available in February of the calendar year. So the PQA, we also maintain with the measure manual associated value sets. This includes our NDC lists that are used to calculate our measures as specified. The PQA staff, we update the NDC list twice annually, February and July, and we distribute the list to licensees to support ongoing monitoring and quality improvement initiatives around the measures. It's important to note that all uses of the PQA measures are subject to conditions as PQA specifies, and it's subject to a license agreement. And then it's important to note also that the measure should only be used as specified and including the intended use and level of attribution as defined in the PQA measure manual. So some of you might be wondering, well, how do I request a license for the measure manual and or the value sets from PQA? So in the next slide, we'll walk through here the best approach to requesting a license. So for licensing, the best way to request this is to submit a license request form, and there is a link at the bottom here. This is the website link, and if you access that, you will be able to find the license request form. There are a few questions that you have to answer that will help us determine which category of licensee you would fall under. It's pretty simple to get through though, and it is required for you to have access to the measure manual and the value sets. We also have a potential license for researchers. So that would be a different form, but they're all linked in and available on that website. And I think it's important to note also that one of the benefits of being a member of PQA is that you can request a royalty-free license for the measure manual for non-commercial purposes. So in the purple there, you can find information about the royalty-free license, and you can access that again through the PQA website. And if you have any specific questions on licensing, you can email this particular email at measureuse@pqaalliance.org, and we can help answer any licensing questions you may have. Next slide, please. All right, and then last but not least, we are available to provide technical assistance about questions or measure specifications and value sets. You can submit those questions through our technical assistance form, which is accessible on the PQA website, and there is the web link there as well. You typically will receive a response within 1 to 2 business days. And we also encourage you to visit our measures overview page on our website, which provides some frequently asked questions and answers that might help provide direction on any questions you might have. So that will wrap up the information on how to request license and submit technical assistance questions. And now I'd like to turn it over so we can review some of the questions that were submitted. Sorry, let me find that. Okay. So for the team, and I think I'm going to send this one over to Ben. There was a question we received about how PQA plans to pursue NQF endorsement for additional measures. Ben, do you want to address that question?
Yeah, absolutely, and it's a good question. So really, implementation is typically going to be the driver for pursuing NQF endorsements, especially I think in CMS programs, but certainly other programs as well. So we are pretty strategic about pursuing NQF endorsement, typically only when the benefits that we think it will confer as far as advantage and potential adoption outweigh sort of the costs in terms of staff time, et cetera, for guiding and stewarding measures through that endorsement process. I know that this question asked specifically about the CVDM measure. That's the use of cardiovascular medications in persons with diabetes. I think I'm butchering the full name of that, but it has to do with the use of certain medications in persons with diabetes to reduce cardiovascular risk. So for that measure specifically, we don't have plans in place at present to pursue NQF endorsement. We are pursuing projects with a couple of different organizations to implement that measure. And if it does turn out that there's interest and potential for implementation in a way that would benefit from NQF endorsement, it's absolutely on the table in the future.
Oh, sorry, thank you, Ben. And I see we have an additional question about, let's see, which of CMS's additional programs beyond the plan level programs does PQA see as the best opportunities for measure implementation? How would PQA characterize a prioritization strategy associated with doing so? So I'll turn this over to Lisa.
Yeah, so we get asked this question a lot. Our measures can be used for quality improvement purposes as they're specified. However, to be applied at a different level of attribution, they'd need to be tested for scientific acceptability. So that is an important consideration before PQA measures would be applied to some other level of attribution or evaluation. As I stated, the opioid measures have been tested at the ACO level, Accountable Care Organization, and other measures have been tested and are used in programs, but they're not ready for implementation in CMS programs beyond the health plan measures currently. Obviously, we would like to see a quality program for pharmacies. That would be fantastic. And we're very open. You have to be very purposeful, though, about the attribution of like if you take a measure at a population level, like a health plan or a state, and then bring it down to a smaller attribution level, for example, providers in the MIPS program, measures need to be evaluated specifically for that use. But we're always open to ideas and opportunities for testing as well.
Thank you, Lisa. Let's see. Sorry, I'm just reviewing the Q&A here. Oh, there's another question about disseminating best practices to help plans and states perform better on their measures. Who would be willing to address that question?
Yeah, I can jump in on that. And it's a great question because dissemination of best practices, right, which I think falls under the umbrella of education, that's one of PQA's pillars. So getting that sort of information out there is pretty core to PQA's mission, and it's an important priority and part of what we do. And there's a lot of different avenues that we take to sort of spread the word on this sort of thing. We do quality forums very regularly for our members, so that's an opportunity to disseminate best practices for folks to share innovative work that they're doing, cutting edge work, new interventions, really any range of quality related information can be disseminated through those webinars that we do frequently. PQA does grand rounds with a number of different organizations during which we can provide different quality education, discuss, learn, and disseminate best practices, et cetera. Through our research branch, we do a lot of research internally at PQA related to medication use quality. And as a part of that, as with any research organization or part of an organization, dissemination is an important part, whether it's abstracts, posters, journals, podium presentations, roundtables, whatever it may be, always trying to get the word out on the work we're doing in research. We have the annual meeting and the leadership summit as sort of more public forums to both allow members to present on their work, but also, more informally, PQA likes to encourage member-member collaboration. As our membership czar, Lauren Kirk, likes to say, we like to be the catalyst to make connections between different organizations so they can communicate and learn from one another. So I could probably keep going for a while, but there are a number of different avenues that we have in place and different pathways for us to connect members to the most recent quality information and knowledge.
Thanks, Ben. Sorry, just keep an eye on time here. So we have a few more questions to get through. One of the questions that came in is, can you address what measures have been dropped in the last couple of years? I'm assuming that's from Part D stars. I'm going to turn that over to Lisa.
Sure. Yeah, actually, we had a slide on this. So next time we'll put it in. It's kind of fun to see the progression over time of the program, and you can access this in the public domain. But a few measures that have been retired over time by CMS include the high-risk medications in the elderly, the HRM measure, and they recently retired the drug interactions measure. Mm-hmm. And there's a composite measure that they also retired, the high dose and multiple providers measure. So they kept the two individual measures. And, PQA also evaluates our measures for retirement and communicates those. We have actually plans for a retirement vote this December for the HRM and drug-drug interaction measures. So it's something that we monitor and evaluate performance over time. And I can't think of anything more off the top of my head. Oh, there was a diabetes medication dosing measure as well that was retired. But happy to follow up on that and where to access that information. Thanks.
Thanks, Lisa. And I think the last question we'll be able to get to today based on time is, there's a question about the process for which benchmarks for adherence metrics are determined in the star ratings. So Ben, I'll let you chat a little bit about that.
Yeah, another really good question. So first of all, the question, is it done by PQA or CMS? That is CMS. PQA does not have, control or oversight over those cut points. That's what we typically think of as an implementation aspect of a measure. It's specific to the Part D program. I can speak to this very briefly. I recommend that anyone who's interested in the nitty-gritty refer to the technical notes for the star ratings, which is sort of the key text for this whole program. You can find it by just Googling Part D star rating technical notes. But essentially what they do is they take all the scores, they run an algorithm called a hierarchical clustering algorithm. And what that does is it takes all the scores and it identifies gaps in the clusters of those scores, essentially, such that after running it, there are 5 non-overlapping groups that sort of reflect natural divisions in the distribution of the data. And those are then used to establish the cut points for various stars. So that updates year over year because the distribution of scores updates year over year. That's a very, very simplistic explanation of a complex process. So if you want to really get into it, again, refer to those technical notes.
Fancy words.
Fancy words.
Like it. So I know I'm going to turn it back over to Amanda. And can you just remind everyone how to access the slides after the call, Amanda, as well? I think we've had a few questions in chat about that.
Sure. We will have the slides and the recording for the presentation in the member resources library section of the PQA website within a week or so. I know there's a lot of good information here, a lot of links that you all may want to access. So yes, we will make that available to you. And if you've got questions on where to find that, please reach out and we can help you with that as well. And then let me share my screen one more time here. And we will wrap up with a couple of announcements about how you can be engaged with PQA and some upcoming opportunities. So first, I wanted to let everyone know about our fourth quarter stakeholder advisory meeting. That is going to be held on Wednesday, the 27th of October from 1 to 2 p.m. Eastern Time. And this is going to be a members only staff hosted meeting, and we will share measure development and maintenance updates along with engagement opportunities there as well. The registration link, much like the slides that we just talked about, is also going to be available in the member resources library on the PQA website. And then I would also like to remind everyone about our call for contributions for PQA's SDOH, or Social Determinants of Health Resource Guide. There currently is no resource that catalogs pharmacist and pharmacy-centered SDOH interventions, and PQA's resource guide will provide healthcare professionals with ideas and examples of SDOH services that can be implemented. So we do welcome your submissions to be considered for inclusion in the guide, and please do submit those by the 30th of September. You will notice I've put a couple of links in the chat. One is to the form where you can submit for the SDOH guide, as well as a sponsorship and education email should you need some additional information from us on either of those topics. And then finally, there is also a link related to our Leadership Summit, and that is going to be coming up this year on November 10th and the 11th. We will be holding it in Arlington, Virginia. This year's summit is going to be a hands-on meeting where we'll have key leaders from PQA's member organizations, and we'll engage in a series of interactive discussions about the implementation, the feasibility, and the completeness of Blueprint PQA 2025. So key contacts from PQA member organizations did receive invitations to Leadership Summit, but if you are interested in sponsorship, we do have opportunities for that. So please contact us at that sponsorship email address. And then finally, to wrap us up today, we do value your feedback. I'd like to remind everyone, if you wouldn't mind, just to take a moment and complete the survey that will appear as the webinar concludes. And then one more reminder, the slides and the recording will be available on PQA's website. Check out the member resources library and you will find those there. Thanks to everyone for attending today, and have a wonderful day.